honored and humbled and grateful and many other positive things to be here. Can you hear me okay if I have this mic like this? I'm going to talk to you about a topic that I've been thinking a lot about lately. The idea about whether or not these medications that we call antidepressants really warrant that label. So hence the title here. It may be time to stop calling them antidepressants. And I was thinking about alternative titles since I came up with this title, and I was reminded about when the musical artist Prince changed his name to a symbol, and then he was referred to as the artist formerly known as Prince. So I thought that I could do something like that too. You know, the medications formerly known as antidepressants, but really what we're talking about here is, do they warrant the label that we're using for them? And you're going to have to decide for yourself, hopefully, at the end of this talk. And there's no doubt that these medications have been very effectively promoted. It says, "I'm having such a good time, I feel like we're in a pharmaceutical ad." To the point where this is just part of the background in our media. It wasn't that long ago that I remember seeing an ad on my local TV that told me my weather was brought to me by Paxil that day. And I'm not making that up. And these medications have taken on mythical properties, and they have become extremely popular. It says, you're not the only person in the world who's depressed, you're the only person in the world who's not taking antidepressants. The revenue estimates for antidepressants in 2004 topped $13 billion. Estimates suggest that 1 in 8 adult Americans has taken an antidepressant in the prior 10 years. Of those taking an antidepressant, about 60% indicate they have taken them for more than 3 months, and 46% have taken them for more than a year. This, despite the fact that the modal study on antidepressants lasts 6 weeks. So in many cases, we're in uncharted territory when it comes to safety and efficacy when people are on them for years and years. And just last week, the CDC came out with a report that said that antidepressant use had increased almost 400% in the U.S. since 1988, making antidepressants the most frequently used medication by people in the age group from 18 to 44. So that's how popular they are. And in fact, they found that 11% of Americans aged 12 and older took an antidepressant during the 3-year study period from 2005 to 2008. 11%. That's unbelievable. And less than a third of Americans taking one antidepressant and less than a half of those taking multiple antidepressants have seen a mental health professional in the last year. So patients are taking these medications, but they're not getting therapy in most cases. Another startling statistic in this CDC study was that 25% of American women aged 40 to 59 are taking antidepressants. 25%. So women in particular are being disproportionately exposed to the risks of these medicines. According to IMS Health, in 2010, more than 250 million prescriptions for antidepressants were filled in the U.S., making it the #2 most popular class of drug, just behind the lipid regulators, the statin drugs. And one reason is that for this popularity is that primary care doctors are prescribing antidepressants. And in a recent study, 73% of the time there was no psychiatric diagnosis accompanying the prescription, despite the reservations we have about diagnosis. But patients, in other words, are presenting with symptoms of depression, and they're getting a prescription for the medications we're calling antidepressants. Okay? And as I say, they have taken on mythical qualities. They're seen generally as extremely effective. It's infused into our art, and our cartoons, of course, is, of course your daddy loves you, he's on Prozac, he loves everybody. And this is the kind of thing that appears in our cartoons because it reflects a general phenomenon, a belief about these medicines. Here's another example. This next one is a sad little blues tune about love and pain that I wrote before I started taking Celexa. Okay, so the question is, do these medicines warrant this sort of cultural perspective? Now, my argument is that for an antidepressant or medicine to be called an antidepressant, it should be clearly superior to a placebo. All right, that seems fair, at least as a place to start from my perspective. And a friend of mine and colleague, Irving Kirsch, has done some of the best meta-analyses of the antidepressant data. He used the Freedom of Information Act. This is in 2002, published in Prevention and Treatment, APA Journal, American Psychological Association Journal, to get 38 randomized controlled trials from the FDA database. About 7,000 patients were participants in this study. And these were all the randomized controlled trials used in the initial approval of the 6 most popular antidepressants. You see them listed there. And again, the modal duration of treatment in these studies was 6 weeks. Not years that we're seeing patients placed on these medicines, but 6 weeks. And what he found was that placebo duplicated 82% of the antidepressant response. In other words, the sugar pill did 82% as well as the active drug. So there's just a small margin or advantage for the active drug. It was less than 2 points on something called the Hamilton Rating Scale, a very common scale used for depression in most of these studies. And less than half of the trials in this FDA database actually favored the antidepressant over placebo. But the FDA only requires 2 positive studies to approve a drug for use. And so it doesn't matter how many negative studies there are, as long as there are 2 positive studies. Hence, we have a phenomenon like this, where less than half of the studies in the FDA database actually showed the antidepressant to be superior to a sugar pill. Okay? This is what it looks like graphically. Again, the placebo duplicated 82%, so it just leaves this 18% that might be a true antidepressant response, but it could also be an enhanced placebo response. These studies are supposed to be blind. That is, the patients and the clinicians are not supposed to know which condition they're in. But the question is, are they really blind? Because patients and clinicians know what the side effects are of these medicines, and they can tell from the side effects which condition they're in. So you might be seeing, for this small margin of benefit of the antidepressant over sugar pill, an enhanced placebo effect because of unblinding from the studies. It is statistically significant, but not clinically significant. The difference is so small. Okay? More recently, Kirsch looked at studies submitted to the FDA, whether published or not, and this time he was interested in finding out, well, maybe the more severely depressed patients do better on these antidepressants. And so he took 35 randomized controlled trials comparing new generation antidepressants to placebo. He only included studies for those medications for which the mean change scores were available for all trials. Sometimes the drug company doesn't submit the mean scores because the study doesn't show their medicine to be better than placebo, so they just say it's a failed trial. And so Kirsch said, well, that's not fair. That buries negative data. So we're not going to include those drugs in our analysis. We're only going to include medications for which every trial had at least mean scores. And they did evaluate 5 fluoxetine, 8 nifazodone, 6 venlafaxine, and 16 paroxetine studies. Now this next graph is a little intimidating, but don't be scared off by it. This is from that study. The solid line, well, okay, and I'm going to try to explain it here. The horizontal axis reflects the initial severity score on the Hamilton scale. Okay, so it goes from lower scores to higher scores for how initially severe the depression was prior to the study. The vertical axis is what's called an effect size, the degree of improvement for those patients. And what the solid line is for the drug studies, the dotted line is for the drug condition, rather. The dotted line is for the placebo condition. And it isn't until you get to the very severe range on the Hamilton scale, a score of over 28, which is very severe, that you start to see a clinically significant difference between the drug condition and the placebo condition. In other words, for the vast majority of patients, the active drug is not more effective than the sugar pill. Okay? And those other triangles and circles, the triangles are for the drug, and the larger the triangle, the larger the sample, the circles are for the placebo. But anyway, it's the solid line and the dotted line that are critical here. And the takeaway message is, it's not until they're very severely depressed do you see a clinically significant, clinically meaningful difference. That is something that a clinician would be able to see to the very high range of severity. An independent study done by Fournier, published in the Journal of American Medical Association. The last study was published in Public Library of Science. This is published in Journal of American Medical Association. And the reason I mention that is these are not fringe studies being published in fringe journals. This is not the Journal of Scientology or something like that. This is mainstream medical journals. And what these researchers did was looked at 6 randomized controlled trials comparing SSRIs and placebo. They only used studies that did not include what's called a placebo washout. What a placebo washout is for most FDA trials, what they do before they start the study is put all the depressed patients on a placebo for a few weeks. Anybody who improves on the placebo is kicked out of the study before it starts. Okay, well, you would think that could handicap the placebo condition if you're clicking out all the placebo responders. The rationale was supposed to be that you could get a more accurate estimate of the true drug response. But from our perspective, it handicaps the placebo response. Imagine the converse if you took everybody and put them on an antidepressant, and then if they got better, kicked them out of the study before you started. You know, people would cry foul. But anyway, so they only took studies that did not include a placebo washout, in this case 718 patients, and they also made sure they got individual level data so they could put it all in one big pool. They call it a mega-analysis. And again, this graph is a little bit intimidating, but it's similar to the last one. The vertical axis here is the initial severity on the Hamilton rating scale, from lower to higher severity, and the vertical axis is the amount of change on the Hamilton scale. And the solid line is for the drug condition, or the antidepressant condition. The dotted line is, or the lighter line, depending on where you're sitting, is for the placebo condition. And you can see the change increases the more severe, but it does not become clinically meaningful or clinically significant in this study until a Hamilton score is at least 25, and that's also in the very severe range of depression. In other words, the vast majority of patients who are prescribed antidepressants in a study like this don't benefit compared to the placebo. In fact, they calculated that roughly 70% of the patients who would get these drugs, or more than 70%, would not benefit over a placebo. And I talked to the authors about this, and I was trying to get an equivalent for, I tend to use the Beck Depression Inventory, and he said it'd have to be an initial Beck score over 32 to get into the clinically meaningful difference between the drug and the placebo. Okay? Okay, my position is also that for a medication to be called an antidepressant and to be used as a first-line treatment, the risk-benefit balance should be better than that for less invasive, less medically risky non-drug intervention. You know, it should be better than the alternatives if we're going to call it an antidepressant. And the risk-benefit calculation is almost never made. In fact, most of these studies just emphasize benefit and really minimize risk and don't even, in many cases, report risk. And especially when medicines are combined, you can have problems like this. The Rogaine or the Viagra, one has got to go. Now, what I can tell you about antidepressants is that they are the most common agents used in suicide by poisoning, involved in up to half of serious adult overdoses. SSRIs have the same risk of overdose as tricyclics, but they have lower risk of death in theory, but that's when they're used alone. They may have more serious interactions than the tricyclics, and of course there's risk for things like serotonin syndrome, especially when you combine the drugs. There's evidence that the SSRIs lead to increased prescribing of anxiolytics, you know, the Xanax-type drugs. One Canadian study found that SSRI-related deaths are most likely to occur when patients take 2 or more drugs, including alcohol. So again, sometimes these are accidental overdoses as well. In one study in Massachusetts, they looked at Medicaid patients, and 5,000 patients were on 2 or more antidepressants. 1,100 were on 5, 6, or 7 different psychotropic medications. So this has become common practice. Now, I trained psychiatrists for 30 years, and of course, I would always caution against this, and I'd present the same data to them that I'm presenting to you. But I think the marketing is so powerful that it overwhelms even the data. And I'm going to show you some of the comparative data now, looking at how these drugs compare to psychosocial interventions. In this case, a study published in Journal of Consulting and Clinical Psychology, this graph depicts 3 conditions. Patients were actually randomly assigned to an antidepressant. In this case, it was Paxil or paroxetine, cognitive therapy, or behavioral activation. Most of you know what cognitive therapy is, changing how you think in some of your distorted thinking. Behavioral activation is getting people moving again, getting them doing pleasant activities, exercise, that sort of thing. And there's a placebo condition, and these treatments each lasted 16 weeks. The placebo condition lasted 8 weeks because for ethical reasons, they were concerned about continuing someone on a placebo in a study of major depression. But I do have to tell you, in many cases, in many studies, the placebo patients are the lucky ones because they get to experience the benefit without some of the risks and side effects. Nevertheless, it's quite common to stop the placebo treatment early. And in this case, all these treatments were superior to the placebo at the 8-week mark. So this is the 16-week mark. And what you see here, the dark part of the bar is for those patients who have gone into remission. They no longer meet criteria for depression. Okay? The light part of the bar are the additional patients who had a response. They haven't gotten completely rid of their depression. There's still some residual depression, but they have had a significant response. In many cases, they've cut their Hamilton score in half. Okay? So you can see visually from this graph that at 16 weeks, the behavioral activation condition seemed to have an advantage over the cognitive therapy condition, both of which were better than the antidepressant. Okay? Now, this is the follow-up. After the acute phase of treatment, the patients in the antidepressant condition were randomly assigned to placebo or continued antidepressant for another year. The cognitive therapy and the behavior therapy were discontinued. Now, this graph's a little bit difficult to follow, so let me explain it to you. The patients in the antidepressant condition that were switched to placebo, you can see their survival rate. That is, this is just the remitted patients in this graph, all those who were no longer depressed. They didn't stay undepressed. They quickly started remitting, or rather relapsing. And then when, after a year, the the patients who were continued on the antidepressant had their antidepressant stopped, they quickly started to relapse. In the discontinued behavior activation and cognitive therapy conditions, the relapse was much slower. There were more durable benefits. Okay? That makes some sense. In other words, they learned something that seemed to protect them and reduce the risk of relapse, even though the treatment was discontinued. Okay? And this is a cost analysis. It looks at months in treatment and the cumulative cost in dollars. And while the psychotherapy conditions cost more, thank you. Okay, I can't see red, so I'm red-green colorblind, but I'll try to use this. Thank you. While it costs more initially for the psychotherapy, once the treatment was discontinued and it didn't need to be continued, the costs leveled off, whereas for the antidepressant condition, the costs continued to rise because it required continued treatment to sustain the benefit that was seen. So some evidence that there are cost advantages to the psychological conditions by themselves. Okay? And I know I'm covering a bunch of data, but I feel like the argument has to be made by data. I feel a moral obligation to try to convince you with data that these comparisons are what they are. You shouldn't just have to take my word for it. This is one of the best studies ever done, and I used to call it the best comparative study ever done. This was done by Murphy at George Washington University. There are 4 conditions. Patients were randomly assigned to cognitive therapy alone, nortriptyline, one of the older antidepressants, cognitive therapy plus a placebo, and then cognitive therapy plus nortriptyline. And you can see pre, post, and 1-month follow-up. The vertical axis is just the Beck Depression Inventory score. So they start out very depressed at post-treatment at 1 month. You can see visually, you don't need to do a data analysis here, that there were no differences in outcome among these 4 conditions. What was notable about this study is they used an active placebo, a placebo that caused side effects, to try to make sure that the blind would not be penetrated. They also took blood levels to make sure the medicines were being taken and were within the therapeutic range. They counted pills. They were incredibly thorough. And what was interesting to me also, in addition to this acute outcome, was what happened to those remitted patients over the course of the next year. If they, I can't see it, but if they had cognitive, okay, the top bar is cognitive therapy plus placebo, cognitive therapy alone, cognitive therapy plus tricyclic antidepressant, and tricyclic antidepressant. That's the survival curve over the next year for those 4 different conditions. And if they had gotten cognitive therapy, they were more likely to stay well, that is, non-depressed. If they had gotten the